Hello guys, welcome to the answer series of OSCE questions which was asked previously. Sorry for the delay in answering. Uh, Welcome to my channel and let's start with the question answers. The first OSCE question was 45-year-old male who came with complaint of forgetfulness, urinary incontinence. He is a known case of hypertension. The CT scan image is presented to you. You have to tell the diagnosis, symptoms, treatment and the surgical management available for this patient. Now, as we know, the CT scan image is suggestive of hydro, uh, hydrocephalus or the ventriculomegaly. This patient fits into the triad. The triad is known as Adam's triad. Your patient has a dementia, gait disturbance, and urinary incontinence. Other symptoms that patient can present is raised ICT and the UMN sign. The normal pressure hydrocephalus is diagnosed with the ventriculomegaly and absence of cortical atrophy. In our old age, there can be relative ventriculomegaly because of the cortical atrophy. So we have to rule out the absence of we have to rule out the cortical atrophy to call it as a normal pressure hydrocephalus. The index which is used is Evans index. Uh, Treatment, we check for the CSF pressure, which should be less than 25 centimeter of water, and treatment option available is therapeutic CSF tapping and ventriculoperitoneal shunt. The second question was elder female who came with complaint of loss of consciousness. Patient is a known case of hypertension. CT scan image is presented to you. You have to tell the diagnosis, treatment, component of the triple H therapy. This is usually asked in Viva by old examiners, and surgical intervention that are available for this patient. As you can know, the previous image which was shown is a case of IC bleed. There is a hyperdense lesion present in CT scan in a basal ganglia. So most common site for hypertensive bleed is basal ganglia, specifically putamen, followed by thalamus, followed by cerebellum, followed by pons. If patient present with the atypical patient present as IC case present as IC bleed at atypical sites other than basal ganglia, thalamus, cerebellum, and pons, you have to suspect the some other causes of IC bleed, which can be vasculitis, neoplasm, and amyloid angiopathy, as seen in this image. How do you manage such patient? You can calculate ICS score for the prediction of mortality. This was asked in theory exam. Then other is spot sign and swell sign, which indicate the increased tendency of bleeding. You have to manage intracranial pressure. You have to remove the hematoma by endoscopic approach, or you have to do craniotomy. The triple H therapies consist of hemodilution, hypertension, and hyperventilation. Third image was old age came with complaint of weakness of one side of the body. You advise a CT scan. CT scan image is presented to you. You have to tell the diagnosis, treatment option, and thrombolysis criteria. As you can see in the image, this patient has a ischemic stroke. Uh, Treatment option available is thrombolysis, endovascular mechanical thrombectomy. Indication, contraindication, you have to memorize, and they ask you this in your viva. They can ask you this and in your OSCE as well. As this is asked asked multiple times in INI or NEET SS. And the two agents which are used is altiplase and second is tenecteplase. The fourth image, a young patient came with complaint of headache and vomiting. You did a CT scan to rule out recent onset. As the patient has a red flag, you did a CT scan and you have to tell the diagnosis and the management. As you can see, there is a hyperdense lesion near the sigmoid sinus and superior sagittal sinus. This is a case of cerebral venous sinus thrombosis. You have to anticoagulate the patient and treat the ICP. Um, the fifth case is 40 years old male came with complaint of headache and the vomiting. This headache was the worst headache of his life. We call it as a thunderclap headache. If patient has a red flag sign, you have to know the red flag sign of headache and CT scan. This is a CT scan image. You can see the hyperdense lesion in the fissures and subarachnoid spaces. You have to know the diagnosis, treatment, and complication of this. This is asked in Viva as well as in OSCE. For your information, this appearance is known as star of circle of death or star of death appearance. So this case was a case of subarachnoid hemorrhage. Hunt and Huss scale is uh, used for grading the subarachnoid hemorrhage. Complications are re-rupture, hydrocephalus, digital cerebral ischemia, for which you use nimodipine, and you have to manage the hyponatremia. You have to know about the most common site of Berry's aneurysm, which is anterior cerebral artery, and the defect is in tunica media or internal elastic lamina. You have to treat raised ICP, prevention of delayed cerebral ischemia, treat the hydrocephalus. If it's not managed by the osmotherapy, you have to go for the surgical and treatment of the hyponatremia. You have to know the treatment of aneurysm also, that is coiling or clipping. When do you do coiling? When do you do clipping? The BP which you have to maintain in this patient should be less than 160, and you can use IV labetalol for controlling of the BP. Then other things as we have done our residency, you know everything how to manage this case. Next case was a 10 years old boy who came with complaint of headache, weight loss, loss of appetite, and chronic cough. So patient has a sign. A patient has a upper motor neuron sign. Upper motor neuron had a convergence. You get a MRI done, and you see this image. You have to know the imaging modality. Obviously, this is an MRI. You can't see the bone window. Then you have to know the diagnosis. There are multiple ring enhancing lesion. You have to know the differential diagnosis of the ring enhancing lesion. This is one of the most common question asked in the exam. And you have to know the treatment for this patient. As this patient has a classical history of headache, vomiting, patient has a uh, chronic cough and weight loss. So in India, most common is tuberculosis. So you have to know the other diagnosis of the ring enhancing lesions. Uh, so we start patient on steroid and AKT, and you have to rule out the other immune deficient causes of immune deficiency like HIV. And in this image, you can see the basal exudate seen in the patient of tuberculosis meningitis. Then this is the another ring enhancing lesion. This question was asked previously. So you have to explain the MRI finding, differential diagnosis, and what will be your diagnosis in case of uh, immune deficient patient. So this our patient had a ring enhancing lesion with the surrounding perilesional edema. How do you diagnose such cases? CSF analysis, you do check for the CD4 count. Differential diagnosis will be your tuberculosis, NCC, fungal abscess, lymphoma, or it can be tumefactive demyelination seen in multiple sclerosis. Then a young patient came to you with a complaint of blurring of vision, headache. This was second or third episode. You get a MRI of the patient. The scan is presented to you. You have to know the radiological findings, name the signs, criteria used for the diagnosis of in this patient and treatment. This is the most common we see. We have seen this during our NIT UG and NIT PG actually. This is Dawson's finger seen in multiple sclerosis. You have to know the other lesions also, other lesions seen in MRI in case of multiple sclerosis also, and you have to know the signs, that is Lermit sign, Barber's chair sign, Uthaf sign, cortical spinal symptoms, optic neuritis. Criteria usage, McDonald's criteria. Then we come to ninth OSCE. 50-year-old male presented with the myoclonus, actually statal myoclonus. You can see video of statal myoclonus on YouTube. You have to tell the MRI finding and diagnosis of the patient. This is, you can see the ribbon like folding. It is known as ribbon sign seen in Creutzfeldt-Jakob disease. Then 10th OSCE, you see the image and you know about it. We have read multiple times in it UG, PG, not UG, yeah, PG, and during residency. Uh, you have to know the diagnosis, name the appearance, and etiology. So this is a appearance is known as puff of smoke appearance seen in moya moya disorder. You have to know the etiology, which can be genetic mutation on RNF213. Nobody is going to ask you this. You have to tell the other causes like atherosclerosis, hematological like sickle cell disease, vasculitis. Then it can progress. It How does the moya disease progress? It can cause infarct as well as bleed in patient. 11th, a 28 years old female came with complaint of preeclampsia with a BP. Patient had a BP of 180 by 110. You get a MRI of the patient. You see this image. You have to tell the diagnosis, etiology, and treatment. Now there is a hyperintensity in the occipital lobe, most commonly seen in press posterior reversible encephalopathy syndrome. Then you have to tell the different causes. This was asked in critical care need assess. You have to know this. And how do you treat? You have to decrease the BP. You have to manage the convulsions and treatment of the eclampsia. Deliver the patient. Thank you. Subscribe my channel, and we'll be back with new OSCE in a day or two. Thank you.